Management of Premenstrual Syndrome, Green Top Guideline number 48, February 2017. Definition: PMS encompasses a vast array of psychological symptoms such as depression, anxiety, irritability, loss of confidence, and mood swings, as well as physical symptoms, typically bloatedness and mastalgia. It must be demonstrated that symptoms cause significant impairment to the individual during the luteal phase of the menstrual cycle. Classification of premenstrual syndrome. Two types. ISPMD consensus. Core premenstrual disorders or PMDs. Core premenstrual disorders or PMDs are the most commonly encountered and widely recognized type of PMS. The symptoms of core PMDs are nonspecific and recur in ovulatory cycles. They must be present during the luteal phase and abate as menstruation begins, which is then followed by a symptom-free week. There is no limit on the type or number of symptoms experienced. However, some individuals will have predominantly psychological, predominantly somatic, or a mixture of symptoms. Variant premenstrual disorders or PMDs. Subtypes of variant PMDs. Number 1. Premenstrual exacerbation of an underlying disorder such as diabetes, depression, epilepsy, asthma, and migraine. These patients will experience symptoms relevant to their disorder throughout the menstrual cycle. Number 2. Non-ovulatory PMDs, which occur in the presence of ovarian activity without ovulation. This is poorly understood due to a lack of evidence, but it is thought that follicular activity of the ovary can instigate symptoms. Number 3. Progestogen-induced PMDs are caused by exogenous progestogens present in hormone replacement therapy or HRT and a combined oral contraceptive pill or COC. This reintroduces symptoms to women who may be particularly sensitive to progestogens. Although progestogen-only contraceptives may introduce symptoms, as they are non-cyclical, they are not included within variant PMDs and are considered adverse effects, probably with similar mechanisms, of continuous progestogen therapy. Number 4. Premenstrual disorders or PMDs with absent menstruation, which include women who still have a functioning ovarian cycle, but for reasons such as hysterectomy, endometrial ablation, or the levonorgestrel releasing intrauterine system, or LNG-IUS, they do not menstruate. Prevalence and etiology. 4 in 10 women, equivalent to 40%, experience symptoms of premenstrual syndrome, and of this, 5 to 8% suffer from severe PMS. Currently, two theories predominate and appear interlinked. The first suggests that some women are sensitive to progesterone and progestogens since the serum concentrations of estrogen or progesterone are the same in those with or without PMS. The second theory implicates the neurotransmitters serotonin and gamma-aminobutyric acid, or GABA. Serotonin receptors are responsive to estrogen and progesterone, and selective serotonin reuptake inhibitors, or SSRIs, are proven to reduce PMS symptoms. GABA levels are modulated by the metabolite of progesterone, allopregnanolone, and in women with PMS, the allopregnanolone levels appear to be reduced. How is premenstrual syndrome diagnosed? When clinically reviewing women for PMS, symptoms should be recorded prospectively over 2 cycles using a symptom diary, as retrospective recall of symptoms is unreliable. A symptom diary should be completed by the patient prior to commencing treatment. Gonadotropin-releasing hormone analogs may be used for 3 months for a definitive diagnosis if the completed symptom diary alone is inconclusive. What aspects are involved in delivering a service to women with premenstrual syndrome? When should women with PMS be referred to a gynecologist? Referral to a gynecologist should be considered when simple measures, for example, COCs, vitamin B6, and SSRIs have been explored and failed, and when the severity of the PMS justifies gynecological intervention. How is premenstrual syndrome managed? Appendix number 4, How PMS is treated, a decision-making algorithm. First line includes exercise, cognitive behavioral therapy, vitamin B6, combine new generation pill, cyclically or continuously, continuous or luteal phase, day 15 to 28, low-dose SSRIs, for example, citalopram, and or escitalopram of 10 milligrams. Second line includes estradiol patches of 100 micrograms plus micronized progesterone of 100 milligrams or 200 milligrams for day 17 to 28, orally or vaginally, or levonorgestrel releasing intrauterine system 52 milligrams. Higher dose SSRIs continuously or luteal phase, for example, citalopram and or escitalopram of 20 to 40 milligrams. Third line includes gonadotropin-releasing hormone analogs plus add-back hormone replacement therapy, continuous combined estrogen plus progesterone, for example, 50 to 100 micrograms estradiol patches or 2 to 4 doses of estradiol gel combined with micronized progesterone of 100 milligrams per day or tibolone of 2.5 milligrams. Fourth line includes surgical treatment plus or minus hormone replacement therapy or HRT. Are complementary therapies efficacious in treating PMS? An integrated holistic approach should be used when treating women with PMS. Interactions with conventional medicines should be considered. Selected complementary therapies are as follows: exercise, reflexology, vitamin B6, magnesium, multivitamins, calcium and/or vitamin D, isoflavones, Vitex ignis castus, St. John's wort, ginkgo biloba, saffron, evening primrose oil, acupuncture, lemon balm, curcumin, and wheat germ. This is particularly important for women in whom hormonal therapy is contraindicated. It is important to evaluate evidence carefully for premenstrual syndrome, as there is a 36 to 43% placebo response. St. John's wort interacts with other medications. In particular, it should not be used concurrently with selective serotonin reactive inhibitors and can render low-dose combined oral contraceptives ineffective. Cognitive behavioral therapy. When treating women with severe PMS, CBT should be considered routinely as a treatment option. Hormonal medical management of premenstrual syndrome. When treating women with PMS, drospirenone-containing COCs may represent effective treatment for PMS and should be considered as a first-line pharmaceutical intervention. When treating women with PMS, emerging data suggests use of the contraceptive pill continuously rather than cyclically. How efficacious is percutaneous estradiol? Percutaneous preparations give sufficient estradiol levels to suppress ovarian activity. Percutaneous estradiol combined with cyclical progestogens has been shown to be effective for the management of physical and psychological symptoms of severe premenstrual syndrome. When treating women with PMS, alternative barrier or intrauterine methods of contraception should be used when estradiol is used to suppress ovulation. Use of continuous estradiol necessitates the addition of cyclical progesterone or progestogens 10 to 12 days per cycle to avoid endometrial hyperplasia in women who have a uterus. Intrauterine administration of progestogen has the potential to avoid systemic absorption and hence minimize progestogenic effects. The levonorgestrel releasing intrauterine system 52 mg as progestogen replacement can maximize efficacy by minimizing PMS-like adverse effects. Micronized oral progesterone 100 or 200 mg has fewer androgenic and unwanted adverse effects compared with progestogens such as norethistérone and levonorgestrel. Micronized progesterone can also be administered vaginally, which may be better tolerated by avoiding first-pass hepatic metabolism. Vaginally administered progesterone avoids the formation of psychoactive metabolites such as allopregnanolone. When treating women with PMS using estradiol, women should be informed that there are insufficient data to advise on the long-term effects on breast and endometrial tissue. What is the evidence for efficacy and adverse effects of danazol in the treatment of premenstrual syndrome? Cycle suppression may be achieved using danazol, an androgenic steroid. Women with PMS should be advised that, although treatment with low-dose danazol, 200 milligrams twice daily, is effective in the luteal phase for breast symptoms, it also has potential irreversible virilizing effects. These symptoms include acne, weight gain, hirsutism, and deepening of the voice. Women treated with danazol for PMS should be advised to use contraception during treatment due to its potential virilizing effects on female fetuses. Danazol taken during pregnancy is known to cause clitoromegaly, labial fusion, and urogenital sinus abnormalities in female fetuses. These abnormalities occur more frequently with higher doses. However, cases have been reported at 200 milligrams daily. How effective are gonadotropin-releasing hormone analogs for treating severe premenstrual syndrome? Gonadotropin-releasing hormone analogs are highly effective in treating severe PMS. Gonadotropin-releasing hormone analogs suppress ovarian steroid production and therefore cause a drastic improvement or complete cessation of symptoms in patients with core premenstrual disorders, but their effects on bone mineral density mean that they should only be considered for severe cases. How should women with premenstrual syndrome receiving add-back therapy be managed? When treating women with severe PMS using gonadotropin-releasing hormone analogs for more than 6 months, add-back hormone therapy should be used. Continuous combined therapy or Tibolone is preferable to sequential combined therapy in order to minimize the risk of reappearance of PMS-like progestogenic adverse effects. Women should be provided with general advice regarding the effects of exercise, diet, and smoking on bone mineral density. Women on long-term treatment should have measurement of bone mineral density, ideally by dual energy X-ray absorptiometry or DEXA every year. Treatment should be stopped if bone density declines significantly. DEXA is accepted as a gold standard investigation for assessing bone mineral density. Non-hormonal medical management of premenstrual syndrome. SSRIs should be considered one of the first-line pharmaceutical management options in severe premenstrual syndrome. SSRIs appear to be effective for both physical and psychological symptoms. When treating women with premenstrual syndrome, either luteal or continuous dosing with SSRIs can be recommended. Is there any evidence on how SSRIs should be discontinued when used in PMS? Gastrointestinal disturbances, headache, anxiety, dizziness, paresthesia, sleep disturbances, fatigue, Influenza-like symptoms and sweating are the most common features of abrupt withdrawal of an SSRI or marked reduction of the dose. The dose should be tapered over a few weeks to avoid these effects. What are the risks and adverse effects of selective serotonin reuptake inhibitors? Women with PMS treated with SSRIs should be warned of the possible adverse effects such as nausea, insomnia, somnolence, fatigue, and reduction in libido. What preconception and early pregnancy advice should be given regarding selective serotonin reuptake inhibitors and/or serotonin norepinephrine reuptake inhibitors? Women should be provided with pre-pregnancy counseling at every opportunity. They should be informed that PMS symptoms will abate during pregnancy, and SSRIs should therefore be discontinued prior to and during pregnancy. Women with PMS who become pregnant while taking an SSRI and/or SNRI should be aware of the possible, although unproven, association with congenital malformations. They should be reassured that if such an association does exist, it is likely to be extremely small when compared to the general population. Major congenital defects, for example, anal atresia, cystic kidneys, clubfoot, gastroschisis, hypospadias, limb reduction, and omphalocele. Women should be informed how to safely stop SSRIs. Women taking luteal phase SSRIs can discontinue the medication safely at any time, whereas women using a continuous regimen should taper the dose over a period of time as advised by their doctor. Are diuretics efficacious in the treatment of premenstrual syndrome? Spironolactone can be used in women with PMS to treat physical symptoms. How can PMS be managed surgically? Hysterectomy and bilateral oophorectomy is a permanent form of ovulation suppression as this removes the ovarian cycle completely. It also removes the endometrium, allowing the use of estrogen replacement without the need for progestogen. Hysterectomy with bilateral oophorectomy can be justified in women in whom medical management has proven unsuccessful, where long-term gonadotropin-releasing hormone treatment would be required, or if gynecological comorbidities indicate hysterectomy. Should the efficacy of surgery always be predicted by the prior use of gonadotropin-releasing hormone analogs? When treating women with PMS, surgery should not be contemplated without preoperative use of gonadotropin-releasing hormone analogs as a test of cure and to ensure that hormone replacement therapy is tolerated. Preoperative gonadotropin-releasing hormone analogs appear to be of value in predicting the effects of oophorectomy, although such a strategy has never been tested scientifically. It would seem important, particularly when surgery is being contemplated in women younger than 45 years of age and for PMS alone. What is the role of hormone replacement therapy after surgical management? Following hysterectomy, estrogen-only replacement can be used. The avoidance of progestogen prevents reintroduction of PMS-type adverse effects. Consideration should also be given to replacing testosterone as the ovaries are a major production source, 50%, and deficiency could result in distressing low libido, hypoactive sexual desire disorder. Is there a role for endometrial ablation, oophorectomy, or hysterectomy alone? When treating women with severe PMS, endometrial ablation and hysterectomy with conservation of the ovaries are not recommended. Bilateral oophorectomy alone, without removal of the uterus, will necessitate the use of a progestogen as part of any subsequent HRT regimen, and this carries a risk of reintroduction of PMS-like symptoms, progestogen-induced premenstrual disorder.